Hi there, welcome to this warm-up review. Let's get started with the first question. What is the difference between kwashiorkor and marasmus? So kwashiorkor is protein malnutrition. So you would see skin lesions, edema, and liver malfunction. So think about the small child with a swollen belly. With marasmus, on the other hand, instead of just protein malnutrition, you have complete nutrient deficiency and energy malnutrition. So you don't see that swollen belly, but instead you see tissue and muscle wasting and loss of subcutaneous fat. There may be some edema, but is not as prominent as it is with kwashiorkor. Next question. Which vitamins should vegetarians take to supplement their diets? So the main one is vitamin B12. Okay, that's it for this warm-up review. Let's move on to the lecture.
In this video, we're going to talk about erythropoiesis, or the process of making red blood cells, and some things that can go wrong with that process. Now, I've already said you don't need to worry about memorizing all the different cell types that go from myeloid progenitor to pronormoblast to polychromatophilic normoblast and so on. Too much detail. But let's talk about the details that you do need to know. The first primitive blood cell progenitors appear in the yolk sac at about 3 weeks, and then the true hematopoietic stem cells come from the mesoderm, from near the mesonephros region of the embryo. And then after a couple of weeks, these stem cells migrate to the liver. Now, there's a helpful mnemonic. Young liver synthesizes blood. I love mnemonics where the phrase actually links to what you're trying to remember. So, young liver synthesizes blood. So, hematopoiesis starts off in the yolk sac from week 3 until about week 8. And then the liver and the spleen take over. Though the liver is the most important site of hematopoiesis pretty much throughout fetal development. And then beginning around 28 weeks, the primary site of hematopoiesis is the bone marrow. And then make note which bones we're talking about. In infancy and childhood, the marrow of basically the entire skeleton is hematopoietically active. It tends to be things like the sternum, the pelvis, the ribs, the cranial bones, the vertebrae, and also the long bones of the leg, which are the tibia and the femur. So think about those long bones and flat bones. And then around late adolescence or early adulthood, those long bones become quiescent, and you're basically left with the axial skeleton throughout the rest of adulthood. So again, vertebrae, sternum, ribs, and pelvis. And then remember that there are some structural differences between adult and fetal hemoglobin. A molecule of hemoglobin is made of 4 different globin chains. In adults, it's 2 alpha chains and 2 beta chains. Now, the alpha globin gene cluster is found on chromosome 16, and the beta globin gene cluster is found on chromosome 11. So that's adult hemoglobin, hemoglobin A. Fetal hemoglobin is made of 2 alpha chains and 2 gamma chains. Now, what's the difference? Well, those gamma chains have a lower affinity for 2,3-DPG, or 2,3-diphosphoglycerate. And because of that, fetal hemoglobin has a lower affinity for 2,3-DPG and a higher affinity for oxygen than adult hemoglobin does. So when maternal blood arrives at the placenta, and there's a lot of 2,3-DPG around, the maternal hemoglobin lets go of oxygen and binds to 2,3-DPG. And that's how we get that transfer of oxygen from mom to fetus across the placenta. So let's look at the study guide and talk a little bit more about different kinds of hemoglobin that you can see with different globin chains. There are several normal hemoglobin variants that you need to be familiar with, and also some pathological variants. So we said normal adult hemoglobin is made of 2 alpha chains and 2 beta chains, and that's called hemoglobin A. A for adult. Hemoglobin A makes up about 97% of hemoglobin in a normal, healthy individual. Now, hemoglobin A2 is 2 alpha chains and 2 delta chains, and that's about 2 to 3% of hemoglobin in normal adults. Then hemoglobin A1C, we covered that with diabetes. It's just normal hemoglobin that's been, normal hemoglobin A anyway, that's been non-enzymatically glycosylated because the blood glucose was so elevated. So it's hemoglobin A1C, is a subtype of hemoglobin A. Then hemoglobin F is that fetal hemoglobin, 2 alphas and 2 gamma chains. So gamma chains replace the beta chains in hemoglobin A. Or another way to look at this is that as the fetus transitions from fetal hemoglobin to adult hemoglobin during the last few weeks of pregnancy and the first few weeks of postnatal life, the gamma globins are replaced with beta globins. Hemoglobin Gower is present even earlier in development during the embryonic period. So hemoglobin Gower is 2 zeta chains and 2 epsilon chains. Hemoglobin S is what we see in sickle cell disease, where there's a single amino acid substitution in the beta chain from glutamic acid to valine. And hemoglobin C is a similar variant that's also often seen in sickle cell populations, which is a substitution from glutamic acid to lysine. Then hemoglobin Bart's and hemoglobin H are where you don't have any alpha chains at all. We're going to cover those in detail in the next video with the thalassemias. The other part of hemoglobin, besides the globin chains, is the heme molecules. And those red cell precursors have to be able to make heme correctly. So let's talk about heme synthesis and then some diseases of heme synthesis like porphyria. And there are a few main points to know here. Number one, you've got to know that the rate-limiting enzyme of heme synthesis is aminolevulinic acid synthase, or ALA synthase. So you start with glycine and succinyl-CoA, and you make aminolevulinic acid, or ALA, and you use this enzyme, aminolevulinic acid synthase. So definitely know that. And then vitamin B6 is required for that step. Number two, you don't need to know every enzyme and every step in this heme synthesis pathway, but you should know which steps are defective in porphyria and also in lead poisoning. Now, there are several different types of porphyria. We're just going to focus on two of them, acute intermittent porphyria and porphyria cutanea tarda. Now, you need to be familiar with both of these because they're caused by enzyme defects at two different steps. So let's talk about acute intermittent porphyria first. Acute intermittent porphyria is caused by a deficiency of uroporphyrinogen 1 synthase, which is also known as porphobilinogen deaminase. But the main thing with acute intermittent porphyria is to be able to recognize the presentation of the disease. So it's going to present with abdominal pain, which is a neuropathic pain. Those intermediate heme precursors are thought to be neurotoxic. Patients are going to have port wine urine. It's a very dark or reddish urine because of excess heme precursors that build up in the blood and then spill into the urine. And then polyneuropathy, again, this is a neurological dysfunction taking place, psychological disturbances. So again, those heme precursors are neurotoxic and that can lead to some psychological problems. And then the last point about the presentation is that this is precipitated by drugs, so things like barbiturates, seizure drugs, rifampin, and metoclopramide can trigger this. Now we treat acute intermittent porphyria by giving glucose and heme, which inhibit the ALA synthase, that rate-limiting enzyme. So the presence of heme will down-regulate the ALA synthase enzyme so you don't get buildup of those neurotoxic intermediate products. So definitely be able to recognize that. You can also use the acute in acute intermittent porphyria to think of the acute abdomen and acute psychosis. So that's going to help you remember what this disease looks like. The other type of porphyria you need to know is porphyria cutanea tarda, which is primarily a cutaneous problem, a skin problem. You can probably guess that from the name. But this is the most common form of porphyria. It causes blistering of the skin and photosensitivity, so these patients blister when they go out in the sun. They can also get tea-colored urine. They can have hypertrichosis or excessive hair growth. They can have facial hyperpigmentation, and it's associated with hepatitis C and also with alcoholism. Even without hepatitis C or alcoholism, this is nearly always associated with elevations of LFTs like AST and ALT. So it may help to think of porphyria cutanea tarda patients as being a little bit like werewolves. They have hypertrichosis and they're active at night because of the photosensitivity. And then finally, with porphyria cutanea tarda, the heme synthesis enzyme that's deficient is called uroporphyrinogen decarboxylase. So make sure you know those enzymes. Porphobilinogen deaminase is deficient in acute intermittent porphyria, and then the enzyme uroporphyrinogen decarboxylase is deficient in porphyria cutanea tarda. Let's also look at how lead poisoning affects the heme synthesis pathway. Lead poisoning actually affects the pathway in two places. It affects ALA dehydratase, and it affects an enzyme called ferrochelatase, which is the final step. And while you're looking at the pathway, make note that inhibition of this ferrochelatase means that the red cells are going to have increased levels of protoporphyrin. Now, lead poisoning causes microcytic anemia, plus neurological manifestations, and a bunch of other problems we're going to go through in just a moment. Now, children will classically get lead poisoning from exposure to lead paint, either from old lead-based paint made before 1978 when they stopped putting lead in paint, and then it turns to flakes and it peels and it turns to dust. Or they might be exposed to it from lead in construction sites that gets into the soil and then gets tracked into the house. And that lead dust, whether from paint or from the soil, gets inhaled or gets ingested, and then these children develop neurological problems and mental deterioration. Now, adults can be exposed to lead the same way, but more typically adults with lead poisoning have some environmental exposure to lead, like they work at a factory where lead is used in manufacturing. And in adults, lead poisoning will typically cause headache, memory loss, and demyelination. So again, neurological problems. So what specific neurological problems are we talking about? Well, these patients, both adults and kids, can have sort of a global encephalopathy with memory loss and delirium, mental deterioration like learning disabilities. They can also have peripheral nerve manifestations, specifically foot drop or wrist drop. I mentioned that lead poisoning will cause microcytic anemia. We're going to talk about anemia in the next couple of videos, but microcytic anemia means that the red cells are smaller than normal. And the red cells have that basophilic stippling, which are little basophilic clumps of denatured RNA within the red cell, or possibly ribosomes that clump together. And even though a lot of references will list lead poisoning as a cause of sideroblastic anemia with a ringed sideroblast, that's really not a well-documented finding. So yes, basophilic stippling with lead poisoning, but probably no sideroblastic anemia. Lead poisoning can cause lead lines on the gingivae, these dark bluish-black lines on the gums just above the teeth. They're sometimes called Burton's lines. You can also see lead lines on the x-rays of the long bones in growing children along the metaphyses. So where the bones are growing, you see this hyperlucent line. Lead poisoning can also cause colicky abdominal pain, and it can lead to renal failure in adults. So make sure you can recognize those manifestations of lead poisoning. We're going to review them again in just a second. Then finally, how do we treat lead poisoning? Well, there's a lot of discrepancy among textbooks about the best regimen for treating lead poisoning. If you need to give something to chelate the lead, you can use either EDTA or Succimer in either kids or adults. But if you need lead chelation for children with severe toxicity and very high lead levels, you can give dimercaprol plus Succimer. All right, let's go back and look at porphyria and lead poisoning in a whiteboard review. All right, let's take our little Dr. Lewis voodoo doll and we'll review the features of lead poisoning. So first of all, you have CNS toxicity, encephalopathy, memory loss, delirium. With that, you can also have headaches. You can see foot drop and wrist drop. You can have those lead lines on the gingivae. If you were a child, you can see lead lines on the bones on the x-ray. Patients can have renal failure. They can have abdominal colic. And they can have microcytic anemia with basophilic stippling. And while we're here, let's draw the findings of a patient with porphyria cutanea tarda. So these patients have facial hyperpigmentation, they have hypertrichosis, Dr. Lewis will love that. They can get photosensitivity and blistering, especially on the hands. This is associated with hepatitis C, so there's his liver, and maybe he's got a little jaundice. It's associated with elevated AST and ALT. And we also mentioned tea-colored urine. Now, for your prize, let's say poor homeless Dr. Lewis is stuck in a blizzard. He's got some icicles forming on his fingers, and maybe he has Raynaud phenomenon, so his fingers are turning blue. Poor guy, he looks cold. Maybe he needs a scarf. There, nice and toasty. One last topic before we wrap it up, and that's polycythemia. Now, we said polycythemia was just another name for erythrocytosis, and that just means too many red cells. And there are lots of different things that can cause erythrocytosis. So there's polycythemia vera, which is a monoclonal proliferation of red cells, and it's a benign red cell neoplasm. We're going to cover that with the other myeloproliferative disorders in another video. Chronic hypoxia will cause erythrocytosis because you need to increase oxygen carrying capacity. So your kidneys recognize the low oxygen saturation and they start producing more of the hormone erythropoietin. And that stimulates the bone marrow to produce more red cells. So you might see this with pulmonary disease like COPD, or with obstructive sleep apnea, or cyanotic heart disease, or in people who live at high altitudes. You can also have polycythemia from inappropriate elevations of erythropoietin, something like an erythropoietin-producing tumor, and that's going to lead to polycythemia. Now, there are 4 tumors that classically do this. A year or two ago, a student sent us this terrific mnemonic, potentially really high hematocrit. So the P in potentially is for pheochromocytoma, R is for renal cell carcinoma, which is pretty easy to remember because the kidneys are supposed to be making erythropoietin. They're just doing it out of control now. Then the H in high is for hepatocellular carcinoma, and the 4th one is hemangioblastoma, which is a vascular CNS tumor. And it may also be worth knowing that about 60% of trisomy 21 babies have polycythemia at birth. So one way to think about all these causes of erythrocytosis is to think about whether this is a relative polycythemia or an absolute polycythemia. So relative polycythemia just means that the plasma volume is reduced so that the red cell count is increased relative to the plasma volume. So the absolute number of red cells is normal, but the plasma volume is contracted, so you have more red cells per unit of blood volume. Absolute polycythemia means that the plasma volume is normal, and you actually have too many red cells. And you can also break it down by whether this is an appropriate increase in red cell mass, like with hypoxia, as we just mentioned, or whether it's an inappropriate increase in red cell mass because of ectopic erythropoietin production. And then with polycythemia vera, again, this is due to neoplastic transformation of a red cell precursor, not due to excess erythropoietin. All right, let's move on to the end of session quiz. First question, where does fetal erythropoiesis take place? So the mnemonic was young liver synthesizes blood. So it starts in the yolk sac, then it moves to the liver and the spleen, and again the liver is the major site of hematopoiesis before birth. Then around 18 to 20 weeks, the bone marrow starts producing red cells, and that gradually ramps up through the second half of pregnancy and also after birth. And then in adults, which bones does the erythropoiesis take place in? Well, it's basically in the axial skeleton, the vertebrae, the ribs, and the pelvis. Next, what are some of the different causes of polycythemia? Elevated erythropoietin, and again that can be due to one of four neoplasms, pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, and hemangioblastoma. Remember we had a mnemonic for those. Chronic hypoxia because of pulmonary disease like COPD, and that's also because of increased erythropoietin. And polycythemia vera can cause polycythemia, but here the erythropoietin level is low. And finally we said that about 60% of trisomy 21 patients have polycythemia at birth. And the last question, what are the hematologic and non-hematologic findings in a patient with lead poisoning? So the hematologic findings include microcytic anemia, basophilic stippling, and then the non-hematologic findings include encephalopathy, memory loss, headaches, foot drop and wrist drop, there's lead lines on the gingivae, lead lines on the bones in children, abdominal colic, and renal failure. That's it for now. I'll see you next time.